Right. Thank you very much indeed. We're now moving on to the TAVI session, and it's my pleasure to welcome Mark as a co-moderator. And we've got a good panel of Neil, Phil MacCarthy, and Iqbal to talk to us about this topic. So, Mark, you've joined us now, haven't you? If you want to introduce and say a few words.
Well, why don't you introduce Neil, Shak, and I'll introduce Phil.
Okay. All right. So Neil is going to tell us about TAVI update in 2021. So Neil, all yours.
Can you hear me?
Neil, we can now, yes.
Great. So, sorry, IT. Great. Can you see that? Okay. So really, there's just So I'm having the same problem. I can't move my slides on. Mag, did you mind doing mine?
Yes, I will do it. It's coming. They're coming. Can you see my screen?
Great, thank you. So next slide. Great, so there's been a real kind of rapid evolution, really a revolution in TAVI technique since the first cases nearly 15 years ago in all areas, from patient workup all the way through to the procedure and on to patient recovery. And so over the next few minutes, I'm just going to have a whistle-stop tour through each of these points, just with small examples of where we've really made massive changes that have all added up to really a very different procedure to the one that we started off with. Next slide. And so the first really is before we've even started the procedure with regards to patient workup, and we increasingly are using much more modern and high resolution imaging techniques, for example, here with CT, assessing suitability for transfemoral access. And you can see in this patient, we have minimally tortuous, non-calcified large vessels that would be suitable for transfemoral TAVI access. Next slide. And we can see, yeah, just keep clicking, thanks. We can see here that this patient has significant calcium, and we can see that really on the left side here, that vessel is really not suitable for transfemoral access due to calcification and a small luminal diameter. If you click twice, thank you. And we can also see, next slide, that we can also assess things like left coronary height, and you can see here that the left coronary ostium here is very low, and there would be a potential risk of coronary obstruction here with implantation of TAVI. Next slide. And so part of this is really just assessing any problems up front. With regards to TAVI cath lab setup here, we can see that this was really the setup initially with multiple specialties, many people in the lab. And I remember being a junior fellow when you can even get into the lab once some of these first cases were starting. If you click, please. And now you can see really that we have a much slimmed down lab setup with normally a senior and a fellow, a scrub nurse and a nurse crimping a valve. Sometimes there's an anaesthetist, often there isn't anymore. Next, and we do have vascular and cardiac surgery backup, but absolutely not in the room, and not with perfusionists, for example, in the room. Next slide. So with regards to the patient preparation as well, previously patients had a general anaesthetic with central and arterial lines and urinary catheters. If you just click through that, we really don't do any of these things now. So most cases are done under a local anaesthetic. There's no central line, no arterial line, no urinary catheter. And most procedures now, in an uncomplicated fashion, last no longer than 30 or 40 minutes from skin to skin. Next slide. With regards to vascular access, we used to either go blind or use vascular, fluoroscopic guidance. Next slide. But we're now using ultrasound. You can here clearly see the bifurcation. If you click through this, please. And you can see the hip, the femoral head, calcium, and also keep clicking, please. And you can see the wall of the vessel. Next slide. And you can see very clearly the needle. You can see where you're going to puncture. You can ensure that you're superior on the vessel wall, again, reducing your risk of percutaneous closure. With regards to contrast use, we used to use injectors with large volume contrast for aortography. Next slide. And now we just use hand injections because we have all this imaging from CT, and we often use only 40 mils of contrast per case, which is important, especially as many of these patients are comorbid with renal failure. Next slide. We often used to place temporary pacing wires, and this was a source of major complication with regards to tamponade and right ventricular perforation. We now pace often through the left ventricular pacing wire. Next slide. If we do need to use pacing, we use balloon tipped wires, and often we can predict who will need a pacemaker afterwards. We may just preemptively implant a pacemaker, again, just to make that procedure safer and quicker. Next slides. Yep, just keep clicking through that, thanks. And then with regards to the technique, we now know that higher is better. This is a paper from colleagues published last year. This is the Edwards valve, and we can see that the higher we implant, the lower the pacing rate. We still maintain a good paravalvular leak rates due to the skirt, if you click next. And we can see here that, next again, we can see that here, this is a case we've done at Imperial where you can really see the lucent line. Next. And you can see this line that we use to implant high to reduce pacing rates whilst maintaining an excellent hemodynamic result from the valve. Next. And again, with the other major valve on the market, the Medtronic, I know the next talk is on valves specifically. Again, by using fluoroscopic imaging on the basis of CT, we can also predict height. Up you go, next slide. And next slide. And you can see here that we can then use these angles to implant high, again, achieving an excellent valve result, but again, reducing pacing rates and therefore inpatient stay. And you can see on the right slide, that wire up in the SVC is the wire that we've used to pace. So again, you can see there's no temporary pacing wire, there's no TOE. This is a local anesthetic procedure, facilitating early or even same day discharge. Next slide. And what we often now do is take all lines out on the cath lab table. Patients can sit out in 4 hours. They can mobilize at 6. If there's no pacing issue, patients can be discharged within 24 hours. And indeed, at Imperial, we've performed a number of day case TAVI procedures most recently, especially during the COVID pandemic. Next slide. And if you just click through these. So in summary, all aspects of the TAVI pathway have evolved. It's important to anticipate a complication. We've really now slimmed down our procedure now to have a sort of simplified TAVI protocol. Patients are mobilized quickly and are discharged very soon, and routinely 1 to 2 days, but there are certain patients where, in fact, if you proceed early in the morning, they can be discharged the same day. Thank you.
Right, Neil, thank you very much for that very comprehensive talk on the TAVI updates. Any questions, Iqbal, from?
Yeah, so one topic is it's become so simple. Surely it's just an angioplasty, DGH angioplasty. Neil, you do a heck of a lot of complex angioplasty in your district base. What about the TAVI?
Yeah, I think we are definitely getting better at identifying patients, but I think still there are patients that we unfortunately do suffer complications in, and they are savable. So especially, recently we've had a left ventricular perforation with tamponade, but we had the valve in, and once you treated the valve, these patients do recover. They are salvageable with surgery on site, and I think still in patients that have that option, performing these procedures in a surgical site is in their best interest.
Neil, another question. It's sort of a friend of mine, similar age to me, and I'm not going to say how old, had recently contacted me, and he's been found to have severe aortic stenosis, no other issues, and he wanted to know whether at his age he should go for surgery or for a TAVI. What should I advise him?
Yeah, I mean, I think this is the ongoing debate, and really the only unanswered question really is centered around valve durability, and indeed how long these valves will last and what you do if they do degenerate. I think the data is very excellent up to 9 or 10 years. So I think age is a factor in their natural other comorbidity. The latest guidelines, I think, especially in America, would say that over the age of 75, I think TAVI would be very reasonable as a first line, regardless of risk. And between 65 and 75, I think it's a discussion both with regards to technical suitability. If a transfemoral case is the way forward, I think that would be reasonable, and an understanding that in the case of valve degeneration, a TAVI and TAVI approach, whilst it has been done, is not completely established yet. And we don't quite know what the long-term outcomes of that intervention is.
Okay. Any other questions, Iqbal?
No, that's it for the moment.
All right. Any comments from Phil or Mark or anybody?
Yeah, I was just going to comment about this business of TAVI in a non-surgical centre. It is something that is on the table being debated. No country does it at the moment. There have been series published from Austria and Germany doing TAVI in non-surgical centres, but they have shipped in a sort of pop-up cardiothoracic service in the DGH. So they have a perfusionist and a surgeon. The important figures are that 0.5% of TAVIs convert to an open stenotomy in the UK and worldwide, but the survival of these patients is poor, and only about 50% survive to discharge. I think it's 48% survive to discharge, and at 1 year, about 70% of them have died. So the bailout is a dire thing. Of course, that's not surprising because these are patients that usually are turned down for surgery. But it is something that needs to be explored, particularly in areas where TAVI provision is under optimal, should we say, suboptimal.
So, Phil, are you saying that it shouldn't be done at DGHs?
I'm saying that no one does it, but I'm saying that we shouldn't completely write it off at the moment. You know, the only thing to say is that it's not the same as an angioplasty, really, but it's moving towards being like an angioplasty. And I think there will come a time when these figures of surgical bailout are so small that really there's no reason why not to. But it's something that needs to be debated amongst the community.
I mean, I think if I could just add, because I spend half my life in a district and half my time in a centre, as it were. And I guess the other important point to make also is outside of the operating and the physicality of backup, it's also the institutional learning curve that we've all lived through, and also the middle grade and other support that's available in these centres, especially out of hours, which isn't always, which is not always commensurate with the kind of historic tertiary centres with regards to having on-site middle grades 24/7, the ability or access to echocardiography at 1 a.m, etc., etc. But I think it is theoretically possible, but I think we do need to look beyond just putting the valve in, but actually the whole recovery pathway as well.
Yeah, I completely agree. I think we're a little way off.
All right.
Thanks.
Neil, Mark, yeah.
So a quick comment on this one. I think the rest of medicine is moving towards vascular centres, oncology centres, trauma centres. Sorry, somebody called me. Everybody's moving towards bigger centres. So I think we should be moving towards bigger TAVI centres doing high volumes rather than having lots of small ones. Because if it's right for trauma to have a big team approach, and I think the comment that was just made about it being the whole institution, not just the cath lab, is very important. So why would we spread them out into little DGHs when the trauma teams and the vascular teams and the
I think the debate that's being had, Mark, is that 300 people died on a TAVI waiting list last year. And in some parts of the UK, people wait a year for a TAVI. Now, for a 4% monthly mortality condition, it's not acceptable to wait a year. So BSIS is looking into this and is going to hold the centres to account that have a year waiting list for their TAVIs. And if that centre can't provide for the local population, we need to explore a number of options to be able to provide the TAVIs for that. And one of them would be to open centres, but we would have to be very clear, and I completely agree with you, we shouldn't go down the lower volume route, but we can't have people dying on waiting lists, and we can't have centres operating a 1-year waiting list for a condition that has a 4% monthly mortality.
Okay, let's move on, Mark, and we might cover this a bit later on as well.
Yeah, so it's a pleasure to introduce Phil, who already has spoken, obviously, but Phil and I started at medical school on the same day, so I've always followed the success of his career very closely, and it's a real pleasure to ask you to talk on this subject, Phil.
Thanks. So can you hear me? Yes. Well, thank you very much for asking me.
We could before and we can now.
Yeah, I'm just in case some sneaky person had muted me. I'm going to talk about the update with regards to valves, and it follows on quite nicely from Neil's talk. Here are my conflicts. So we've heard what's been happening with TAVI. TAVI is becoming a safe and predictable procedure, and the best data is the TVT registry data, which is several 100,000 TAVIs. This is the pattern in the USA, and we can see the mortality on the left here at 1 year, at 30 days, and in hospital, 1.3% in hospital mortality. And the interesting bars to look at on the right are the black bars. These show the number of cases being done to low-risk patients. So that's in answer to Shaq's question. And the evidence base is certainly moving towards this being a procedure for low-risk patients, to the extent that these are the guidelines that Neil mentioned. They're out 2 weeks ago in circulation, the ACC AHA guidelines, and it says for people with severe symptomatic aortic stenosis over 65 years, TAVI should be considered an option, depending on heart team preference and anatomical suitability. Because of this, the number of TAVIs is rising worldwide. Again, this is the US data. TAVIs exceeded isolated AVRs in the US in 2015 and exceeded all surgical AVRs in 2018, and the number of TAVIs is rising still. Let's talk about specific valves, and I'm going to start with the Edwards valve. Like other valves, the Edwards valve has been involved in some of these low-risk studies, and one of them was our own study, the UK TAVI study. It was an all-comers, pretty low risk. The STS score just over 2, so I guess you'd call this an intermediate risk population. Good numbers, TAVI versus surgery. 57% of UK TAVI patients had some form of SAPIEN device, and you can see there was a trend to an improved survival with TAVI, although statistically they were deemed as equivalent. So that was a good quality all-comers real-world study. The real landmark study with the SAPIEN device is the Partner 3 study, which shows low-risk patients being randomized, TAVI versus surgery. And if you look at these graphs in the figure, you can see that combined endpoint, TAVI does better, death from any cause, TAVI does better, stroke and rehospitalization, an improvement on all metrics. So TAVI beats surgery, but the criticism of this study is it was a highly selected population, and our surgical colleagues say this is not the real world, but it's certainly fairly compelling. Now the SAPIEN's evolved, and the latest iteration is the SAPIEN 3 Ultra. You can see these are the major complications across these registries, and the latest SAPIEN 3 Ultra registry is the S3U, which shows actually down here no recorded moderate to severe PVL, no mortality, and no stroke. So it really is a very refined and slick valve. There's no question about that. The Evolute has also been progressing nicely. This is the Evolute R on the left and the Evolute Pro on the right with a pericardial skirt. And the Evolute also has a nice low risk study. This is Evolute low risk, showing the distribution, mainly Evolute R, but about a quarter Evolute Pro. And again, trend to improved outcomes in TAVIs over surgery, but not statistically significant in this study. Now it gets really fruity when we come to head-to-head trials. Industry not always keen to do these, but this is a Solve TAVI published last year, Evolute R against SAPIEN. And you can see this is sort of 6 of one, half a dozen the other. Primary endpoint slightly better with the SAPIEN. For some reason, stroke higher in the SAPIEN, hasn't been shown in other studies, but PVL and pacemaker lower with SAPIEN. the conclusion from Solve TAVI was they were probably equivalent, but had nuances either way. Choice, the Choice study is an old study. This is 5-year outcomes, again published last year, but low numbers of patients and early iterations. So this was Sapien XT versus core valve. And again, conclusion was they were kind of the same. Now the Portico is a slightly newer kid on the block. It's cheaper, it's a simple valve, but it's certainly a useful addition to our armamentarium. The main Portico study published last year was Portico IDE, where it was compared to the commercially available valves in the UK. I'll just go down. There we go. And these were core valve and Sapien. You can see, interestingly, it found that Portico failed its non-inferiority. In other words, it seemed to be inferior on the basis of mortality and paravalvular leak. But the interesting thing shown on the right is that if you look at the first half of patients recruited, there was a difference between the valves, but the second half of patients recruited, there was no real difference. So it does infer that there's a learning curve with this device. And if you look at long-term outcomes with the first generation Portico, these are quite good. This is quite a large study, good quality, shows lower MACE events and lower death with Portico compared to Evolut. Portico is undergoing refinements. They've introduced the FlexNav. It's made by Abbott Vascular. FlexNav leads to more stable positioning. And when compared to the IDE, this is the same group that did the IDE study. You can see lower complications and lower pacemaker rate as well. So there are improvements going on, and there's going to be a skirt on the Portico soon. What about Accurate Neo? This is made by Boston. Unfortunately, in the 2 head-to-heads involving the Accurate Neo, it failed to meet non-inferiority criteria. Scope 1 compared it to the Sapien, and there was a significant advantage of Sapien, both in terms of mortality and paravalvular leak. And Scope 2 also had an excess mortality in the Accurate Neo group. And at 1 year, this was 8% versus 4%. This is almost certainly due to this PVL that you see with the Accurate. You see at 30 days, quite a large number of patients either have a mild or a moderate PVL. They are improving this valve as well, putting a skirt on it. So we need to give it time and wait the new data. Unfortunately, Boston took the Lotus off the market. The Lotus was an excellent valve to use in this kind of anatomy with horrendous LVOT calcification. They did it for commercial reasons, not clinical reasons, and that was a shame. What's on the horizon? Well, MyVal, you might recognize it, looks a bit like the Sapien 3, and the courts are dealing with that at the moment. But this is a valve which is made by Merrill in India. It's got a larger range of sizes, going up every 1.5 millimeter annular size, and it's also got a large size, 32. And the other advantage which is proposed is that you can remove it back into the sheath, the Python sheath, when you can't deploy it. The other valve to look out for is the Allegra. This is made by New Valvular Technologies in combination with biosensors. It's a self-expanding valve, and the thing about the Allegra is it has very, very good hemodynamics, so it might be very useful in valve-in-valve. So ideally, I think a TAVI service should have expertise in both balloon expandable and self-expanding valve. Get good at one, and there's clearly a learning curve, but once you're beyond that, you'll get good results. So just to summarize, I think TAVI continues to evolve, as Neil has said, supporting its use in lower risk patients with short lengths of stay. The Sapien 3 Ultra and the Evolut continue to do extremely well. Both the Portico and the Accurate Neo are going some very interesting iterations, and we have to give them time. They look like useful and competitive valves, and unfortunately for all of us, I think the Lotus is no longer available. Thanks for your time.
Brilliant. Thank you very much, Phil. Yeah. So before Mark, Phil, this friend I mentioned also wants to know if he goes for TAVI, whether he should go for a self-expanding or balloon expandable. So what would be?
Yeah, it's really good. I mean, so for intermediate risk and low risk patients, you really got to look at the individual patient. And what we do in our heart team is say, look, this is a patient that could have surgery. They could have a 3% pacemaker risk. They could have a 0 PVL. That's what you're competing with. That's the gold standard. And you've got to look at the femoral access. You've got to look at the anatomy. You've got to look at the ECG to see what the pacing risk is. And you've got to say to yourself, can I deliver a TAVI valve with a minimal chance of PVL, a low pacing risk, and a low stroke rate. And if the answer is yes, then I would favour TAVI. And I think the literature is suggesting that. The data as it's published is slightly better in that patient cohort for the SAPIEN 3 Ultra. I'm not saying that because I'm partisan to that valve, but nevertheless, either the Evolute or the SAPIEN are both good choices.
Mark?
I was going to ask Phil whether he took into account the valve area that you achieve with a transcatheter valve, because my understanding is that that's significantly better than you get with a surgical valve. And ultimately, if you're putting in a stented pericardial leaflet valve, you're putting in more or less the same, whether it's a SAPIEN 3, which is metal and cow, or whether you're putting in a perimount, which is metal and cow, but with a smaller valve area.
Yeah, I think it's an interesting point, and certainly PPM, patient prosthesis mismatch, is much more commonly seen in surgical populations. In fact, no one has shown that PPM has any effect on survival in the TAVI population. We get better hemodynamics with TAVIs, and so I think what you're hinting at, Mark, is if you put a TAVI in an intermediate risk patient and they live for 10 or 12 years and their TAVI wears out, you might get a better hemodynamic with a TAVI in TAVI than you would with a TAVI in surgical valve. So I'm with you.
Phil, can I ask, so if you have this 70-year-old gentleman who's well, has anatomy suitable for a transfemoral TAVI with a low risk of complication, what risk are you quoting them for that procedure?
Yeah, I would quote them a 1 to 2% stroke risk. I would always use a sentinel in my low and intermediate risk patients if they're highly functioning cognitively. So I do them with cerebral protection. I'd use a 1 to 2% stroke risk, 1% 30-day mortality, with a SAPIEN 3 to 5% pacemaker risk, and perhaps a 1.5% vascular injury risk.
Okay, any other questions, Iqbal, or anybody else?
Oh, I was going to put Phil on the spot and say, okay, his mum, hopefully she's alive, I'm not dropping him into hot water. His mum is well. His mum needs a TAVI or surgical AVR. It's a sort of similar question, but I'm going to personalize it because I know my mum would get an Edwards valve if she was suitable for an Edwards valve. I'm going to put it out there. Phil, are you going to agree with that or disagree?
So my mum's 86, feisty and doing very well. She's a carer for my brother. She'd need a 1 or 2 day inpatient stay. She'd get a SAPIEN 3 Ultra with cerebral protection.
Does everybody use cerebral protection?
No, actually, Shaq, it's interesting. We are actually engaged in a very big, exciting trial called Protect TAVI, funded by the BHF, run by Raj Kharbanda in Oxford, comparing all comers, cerebral protection against none. No one's ever proved it in terms of clinical outcomes, but they've proved it in terms of MRI data. So there's this surrogate of MRI hits after a TAVI. We want to try and prove it with clinical endpoints, so neurological assessment. So it's an exciting area, but it's dead easy to put in. It takes 2 minutes to put in, and you know, I would, if I had one, why wouldn't you have it? It's put in radially. I mean, it's easy.
No, I'm just surprised that people don't use it.
Yeah, well, they do. You know, in some countries, Thorax Centre, Nick Van Meeghem uses it in all his patients.
Yeah. Any other questions before we move on then? If not, let's keep going. Thank you very much, Phil. Excellent, stimulating talk. So we're going to do a recorded case now from Iqbal, a Transcaval case. Iqbal, all yours.
Thank you so much. So the video has no sound, so I'll be talking to it except for maybe the start. So let's I've got control, so I will play it, and I think we won't pause it. So if you have any questions, just ask as we go. Okay, so why Transcaval? Do we do a lot of it? No. Should we have it available? Yes. Should we practice it? Yes. And in some places, it might become the other route of choice when it's not a standard transfemoral. And it involves a lot of planning, an MDT meeting, a team-based approach, and probably proctoring. So planning starts with CT, and you need to have a puncture point. If your puncture point is right next to the kidney or right by the bifurcation, you won't be able to get a covered stent into it. And the nomenclature developed in America is that the middle of L3 is L3.0, and L3.9 is actually just above the middle of L4. So you get a table like this, which tells you whether it's feasible or not, whether the target angle is right, what angle you use in the cath lab, what size stent you would actually need to bail out, and so what's your working length. And of course, you need a little bit of anatomy lesson about celiac axis and the SMA and the renal arteries to produce a puncture point. These patients are never going to be easy, are they? Because the reason you're using it is because there's no other access route, as we'll illustrate with the case. And the angle that you're going to puncture at needs a distance. I'll talk a little bit about why in the world this MAD technique works in a minute. So you can try and get your landmarks in the cath lab, having got it on the CT scan, and hence the reason for knowing your L3.0 is the middle of L3, if you see what I mean. So as we move along in this case, I'll go through the technique and then we'll go through the case itself. So have your bailout kit available, know what expansion length you need. 10% oversizing of your aorta with a covered stent stops your surgeon getting in. And this is probably the key slide because it's a stiff wire inside a piggyback converter, inside a Navicross support catheter, inside a guide catheter, and then you're actually going to burn a hole in the aorta and snare your wire. So you need an old style burner. The new ones do not seem to work. So once you've got it, you're going to produce a loop, a snare inside the aorta. And then when you snare it, you've got a rail. Why does it work? Because your retroperitoneal pressure is higher than your IVC pressure. So if you have a small leak, blood can go through. And as long as you don't block the IVC, then you're going to be fine. It'll leak out. And you can put a plug in to plug the hole in the aorta. If it's a slight leak in the aorta while it's healing up, it doesn't matter as long as you've got a hole in your IVC. We found in our case that actually we couldn't cross into the calcified aorta, and we actually had to balloon it. So you'll see that happening as well. And then a small amount of extravasation is not a bad thing. You don't have to have an absolute seal. And sometimes if you lose your wire position because there is a hole in the aorta, with an Agilis sheath, thankfully we haven't done this yet, you can find the hole again, regain access and plug things up. So you can save the situation even if you've been very cat-handed and lost all access with a hole in your aorta. So this gentleman in his 80s, good LV function, severe aortic stenosis, and with a CT scan showing he's very reasonable for TAVI from the top end, but terrible, terrible leg access. He's got a degree of renal impairment. So he's not transfemoral because of the fat, but also calcified tortuous iliac, lung disease not transapical, axillary, too small, too calcified, very high stroke risk. And the balloon valvuloplasty, the legs were so twisty that we thought we'd even have difficulty with getting a balloon up across there, as we found when we actually started to do the case. So again, the bailout stents are going to be available. And we're going to start with ultrasound guided access of the groin arteries, and then the fun actually began. So we had a very, very tortuous right femoral, took an armored sheath to actually just get to above the bifurcation, and that was with multiple wire exchanges and stiff wires. And the right-sided vein, which is going to be our main access, 2 proclides just for extra safety. 1 probably would have done, but 2 proclides for extra safety. And then you have to have a choice of guide catheters available to make sure you poke in the right direction. So you can see the twist in the leg and the calcification, which is what our challenge was, with an armored sheath to set in there. And then we were hopeful that because it was a 7 French armored sheath and 8 French sheaths to deliver a covered stent, if we had to, was going to be safe. We're then going to get a catheter up from the, so we can see, I think it's a good illustration of the armored sheath going up and the twists that it actually took. So then we've got a pigtail to mark our spot, and then we're going to get a snare out into the right puncture point in the aorta, waiting to receive our wire. This is really a 3 senior operator procedure. I think it's very difficult to do with a lack of personnel in the lab. So a 50-watt cutting diathermy for those who don't use diathermy regularly, and we wanted to get through first time, but we didn't. Now, when we're pushing with the stiff wire, so this is just attaching up the bovie, clamp it up with a scrape of the wire. The wire, remember, has been cut so that the flexible bit has been taken out. We don't use the stiff back end, but the stiff bit beyond the floppy bit of the top end. And so as you're pushing through, the idea is not to advance the wire too far, because you can, of course, take this wire if you keep on buzzing to the other side of the aorta as well. So we're going to position it and advance the wire so it just gets into the aorta. So you can do 2 views. A biplane lab is handy. So you've got in the middle of the bullseye, and then you're going to just advance the wire while you press the diathermy for just a moment. So that one bounced, just bounced straight off calcium. And so then we repositioned just millimeter difference, and then went forward again to try and get the wire into the center of the snare. So that wire is just beginning to be in the bottom end of the snare, hitting the other side of the wall. And so now I think I'm going to be drawing the snare down slowly to see if I can capture the tip of the wire, because that's all we need to do. And we were assisted ably by Toby Rogers, who works in NIH, a Brit who works in NIH, who's been one of the pioneers of this technique, who was just talking us through how to actually do this when this was our second case a few years ago. So as we try and capture the snare, we're drawing it down very delicately to try and capture the tip of the wire. Once we've captured the tip of the wire, we now hopefully will have a rail. So we draw it into the catheter. So we've bent the wire into the catheter so it's held pretty firmly. It's not going to release itself at a wrong moment.
Can I ask a question?
Yeah.
I'm not familiar with this diathermy technique. I mean, obviously the congenital guys like Shak and I are very familiar with the radio frequency kit that we use, which presumably isn't powerful enough for this. Can you just explain to us exactly what you're using? Because it looks a little bit handmade, really. Have you so explain?
Yeah, it exactly is. So basically the diathermy that you might have the pacing guys using to tidy up the wound, or the surgeons using as a cutting and coagulation diathermy, we use cutting diathermy. So you put a pad on the leg, and it's basically exactly the electrode paddle that they use to actually cut, the surgeons use, so it's available in your hospital. Just scrape the end of the wire, clamp it to the paddle, and it's one small sort of press on the knob to actually do the cut for just a second as you push.
Thank you very much.
And presumably you've got no idea how much energy is actually being used, is that right?
Well, we put it on 50, so it's pretty high anyway. So whenever I'm doing a transeptal, and I do a transeptal with the same if I've had difficulty rather than a specific radiofrequency needle, I'm using 30, but this is a very calcified aorta. So just to go back to where we've got with this technology now in the case, so we had to balloon with a 3 or 4 millimeter angioplasty balloon, because nothing would actually cross the aorta, even the Navi cross wouldn't go. Once we've ballooned, then on that rail, which we've taken all the way upwards to the ascending aorta, we were then able to get our Navi cross through, then our guide through, change over to a stiff wire, and then it becomes a pretty straightforward TAVI procedure from that point onwards. So as long as you make sure that your sheath that you're using for your TAVI is obviously longer than from your puncture point to your aorta, otherwise it won't reach, and that'd be a very disappointing thing to find out at that moment when you have a hole in your aorta. So here's the stiff wire going up. And beyond this point, it'll become a TAVI procedure.
Also, Iqbal, whilst it's playing, if in the region where you want to burn, you find that there is a lot more calcium extending higher up, then is it essential that you do it at that point, or can you go higher? Or?
So the planning is key. So the puncture point's been chosen from the CT scan, and I think I would certainly not with my level of experience suddenly change my mind and go somewhere else, because I think we've chosen that spot to be close between IVC and aorta, to have no bowel in between the two, to have a calcium-free spot. So I think if it's a small change of angle, then I think that's fine. But I think choosing a fresh spot because you think you can find a better spot in the cath lab, I think would be very dangerous, because you've planned it with your covered stents and your puncture point specifically from the CT. Okay, so we've taken our standard aortogram, as Neil said before, with an AL catheter in the left sinus and a pigtail catheter in the non-coronary sinus, and really 10 mils of dye gives you the picture. I just don't fully understand why some people do a full aortogram these days. We've then crossed. It's a standard TAVI technique now. In those days, especially with that patient old, we're still using a formal temporary pacing wire. And I think because of the new access route, I think we did that just to have an extra layer of safety. I think if we were doing it again now, I wouldn't bother with that. I'd use pacing via the Safari. But this is quite a horizontal aorta. There was nothing easy about this guy. Forget just the access. There was nothing easy about it. And so you can see we're trying to get a Safari wire, a stiff wire, other manufacturers are available, into the left ventricular apex. And then we're using an Evolut valve because he had quite a lot of LVOT calcification. And therefore, one of the reasons choosing one valve against another is that LVOT chalk. You might go and push that with a balloon catheter into an unfortunate position in the aortic root and cause an aortic root trauma. And this valve was quite difficult to position. It popped a couple of times while we were positioning it, but it's retrievable. So as long as you haven't deployed it too far, then you can retrieve it again. And I'm sure the congenital guys are very used to doing pulmonary valves. I don't think you've got a self-expanding valve for that. But repositionability.
Yes, we have.
You have, fantastic. So you have repositionability is quite useful. Sometimes it's counterproductive because the Edwards, one shot, and I must say I've never lost it in that position in that one shot. The Evolut does move up and down a bit, but if you have LVOT calcification, you want to position it carefully. I think it's not unreasonable to try it, and that's why we used it in this particular case. So unpeel slowly. I tend to have a hold of the Safari wire and the catheters, and someone else unfurls it slowly. Some of my colleagues don't hold the wire, but I find it gives better control to me. And so I think this is probably the actual deployment. It looks as though it's held in position. And we were doing this under local anesthetic. And because you are, then I think I need to remind you that that burn hurts. So when you burn the hole in the aorta, that's quite painful. So you need to give the patient adequate sedation and at least the warning, because otherwise they'll jump. So this is just a standard part of the TAVI procedure now. We're assessing the
Well, you keep that pigtail in place.
So again, people vary. So I must say I've never managed to trap a pigtail so that I couldn't pull it out. Once I do, I'll probably start pulling it back at this moment. But it's quite useful to have it in position, to know where exactly you're deploying it all the way. And I think if you've got a very tight sinus, you might choose to pull it back. But I must say I never routinely pull that pigtail back, either with Edwards or with the Evolut.
And with all the calcium and disease that's diffuse, no cerebral protection?
So we don't have it routinely. And actually, to be honest, until there is absolute data, you are putting another puncture in. You are putting devices up into 2 of the head and neck vessels, but not the 3rd for some reason. And so once we get the an umbrella type device, which they are coming on the market, which don't do an additional puncture, and which actually protect all the head and neck vessels, I'll be much more in tune. But we're taking part in this trial as well. And I think if the trial gives us the answer, then of course we will. But at the moment, although Phil obviously uses it in a number of his cases, I don't, because how do I pick the cases that I do it on? It's very difficult. It's unpredictable. So in the case here, we've got to the finish line where we've put an ADO 8mm occluder in. We used an Agilis sheath to direct it so that it was pointing in a nice angle while we deployed it. And then we've checked with an angiogram to say that we've got a pretty good seal and a flat. So he wasn't out of the woods because he then dropped his hemoglobin. And we, of course, thought he'd had a major retroperitoneal bleed because we'd done something incorrect. In fact, unbeknown to us, he'd stepped out of bed, fallen over, whacked his kidney, and had a perinephric hematoma. So he didn't have a retroperitoneal bleed, but a perinephric hematoma. So I think 3 pairs of hands, a good proctor to tell you exactly how to do it in the first few cases, produces a really good result in people where you don't have an alternative access route. I must say, we use a lot of auxiliary now as our second access, and percutaneous auxiliary is also good. But in those where you can't do that, then, or you want to develop this as the sole other technique, I think it's very reasonable. We screen all our patients to say if this can be done. I would say that we find that probably 30–40% might be suitable for this. There's usually something badly wrong with the aorta, or the space is too far away in the 70% that we can't do it. Thanks very much.
Great, thank you very much indeed. Mark, any comments at the moment?
Yeah, well, it was a lovely case and a very nice demonstration. My question is really that these patients are always the ones with really bad access, and having this standby covered stent to fix the aorta means that most of the standby covered stents go through access sheaths bigger than the Evolute. But I guess the tortuosity here was maybe what made you think it was, you went for it that way. But what do you think about that bailout, relying on a bailout that relies on very big iliacs when you're doing the procedure for bad iliacs?
Yeah, no, I accept that. And we had a vascular surgeon nearby as well who would be able to cut down if we needed bigger access. His size was fine. It was the tortuosity that was the problem. So we thought we'd get away with it here. I think you can get some which are now 8 French compatible, which go up to about 16–17 millimeters on the aorta. So they just unfurl more and more. It begins with B. I've forgotten the name of the company now. So we had those available in the lab as well. So if you can get an 8–9 French in, then you can probably cover up to an 18 millimeter aorta. Obviously, if your aorta is 30, you're going to have big access, I agree.
Mm.
Can I make a comment?
Yeah, go on.
So I mean, I agree with you, Iqbal. It's a sort of elegant technique. It's been around a while. We did 7 or 8 at King's a couple of years ago with Toby and the guys proctoring us. It hasn't really got the traction that we thought it would get over the world, and that's probably because transfemoral systems are improving all the while, and we're getting more daring with transfemoral access. And one of the problems is that if you're only doing very few cases, you don't get very good at it. I mean, it relies, the reason they don't die of a retroperitoneal bleed is it relies on this arteriovenous shunt, and it's what the techniques demonstrated is you can have quite a big shunt between your aorta and your IVC and sort of remain stable while you sort things out. But if you block with your sheath the IVC, you're going to bleed out in 30 seconds. So it's a question of maintaining that flow from the aorta to the IVC. I mean, the only thing to say, Mark's point is really well made, because when things go wrong, they go very wrong. And we had a retroperitoneal bleed during the procedure from one of these terrible porcelain aortas, which have no compliance at all, which required 4 covered stents to stop. The last 2 were over each other because it was just leaking down the sides of all the calcium, and you couldn't achieve a good seal with a covered stent. And she did very well and went on to have a transapical TAVI, actually. But it just made us think that, when things go wrong with this technique, they really do go wrong. I like it, and I hoped it would get more traction, but I'm not sure we're going to be doing it in 5 years.
And you briefly mentioned it there, Phil, but so what is against going straight for transapical TAVI then?
Well, the TA TAVIs don't do well, Shak. I think that what's happened with alternate access TAVI is none of them have done terribly well. There's been a big gap between transfemoral and virtually everything else. The subclavian has I think, done better, and I think most of us would put axillary and subclavian in a sort of intermediate class. And then the TAs, they just haven't done well. It hasn't been a good technique. And, certainly when we're getting into intermediate risk, I think patients should have an AVR, a good surgeon doing an AVR rather than a TA case in an intermediate risk patient. So TAs don't do well, and we only do them sort of when we really have to and can't think of anything else. Sometimes patients don't have good subclavians or auxiliaries and you have no choice. And you think, well, look, the only thing we can do is a TA. So we do occasionally we do about 5 a year, but I think if you can find a an alternate access that isn't TA, that's probably better. And I had hoped that the cable would be one, and it may do, but I think to get good at it, it's a complicated technique. You have to do lots, and I'm not sure you're going to get lots to do.
Phil,
I also just make the point that all the superiority, or the benefit of TAVI is really in, as you say, transfemoral cases with no other, isolated aortic stenosis transfemoral. So especially with the lower and intermediate risk. And so I think if the minute you start thinking about alternate access or multiple cardiac procedures in one, then I think you do have to consider a routine surgical aortic valve replacement, which is a very good operation with great data. So I think we have to really separate our thought process.
Or consider that you might be just nudging them towards the end of futility when you're getting patients with so much comorbidity. Are you really going to offer them a really good 1 year quality of life and survival?
Can I ask a question to Iqbal and Phil?
Yeah, go on, John.
Yeah. So, I mean, I don't do TAVI, and I thank my lucky stars I don't actually. But one of the things that I am very familiar with is stenting aortas, and this is where I get concerned really, and all the things that you've said about getting in a decent sized covered stent. Is there any data about what happens to these patients if they need to have a covered stent inserted, i.e. when complications occur?
There's a good series that Toby has done, colleagues, in the US, and they've got their bleeding risks and categorizations quite clearly, and they've got a lot of bailout stuff. So there's good data about bailout, and they think really hard about it. And Toby and his colleagues have really tried to refine this in a very responsible way. They haven't been gung-ho in just sort of trying it out. They've got a reasonable series, actually. There's several hundred patients that have had this quite successfully, but the bleeding risk is quite high. I mean, I think significant bleeding events, I can't remember, Iqbal might correct me, but it's up in the sort of 20-odd%, which is perhaps not surprising.
Yeah. Well, I think it's a question of what you call a significant bleed. So bleeding that's needed re-intervention is below 5% now, but they're a very experienced centre, and they would tell you that their second line access is Transcaval. In their lab doesn't bat an eyelid now. You try and do a Transcaval in an English lab, they're going to think, my God, he's gone mad again. What's wrong with him? But if you do it often enough, then it just becomes a TAVI. Yeah. And I think Phil's right. If you're going to use that as your second access, you have to use it as your second access and get good at it. But we've actually found that the percutaneous axillary is working well for us. And actually, I've gone back towards transapical because we've had some really good results with day 3 discharges for our transapicals. I don't quite know what's changed, but we had some terrible transapicals, and now we're getting a run of quite decent ones when there is no access available. So I don't think
it's about the centre and what you're good at, Iqbal. You settle on your technique, don't you? You do it in a reasonable volume, you get over your learning curve, and you get good outcomes.
Yeah.
Shak, I just wanted to say another word in favour of apical. I think we do a reasonable number of apical. We finally found a surgeon who's really good at it. To Phil's point, and we tend to do apicals for people who've had previous grafts or previous surgery, so that the actual access, controlling the access, is much easier when you've got that additional scar tissue there. So I think, like any case, carefully selected apicals are a reasonable way forward.
Yeah, I mean, we had been keen to maintain TA access for the fully percutaneous mitrals, which haven't really come online as quickly as we would have wanted to. So we were keen to maintain that expertise. And Olaf Wendler, who I worked with, did the first one in the UK in 2007 and has been an enthusiast of TA access. But on the whole, I just sort of think if I do try and get, like as Neil says, you really got to try and get transfemoral access with your vascular surgeon colleagues. Try and get the device up transfemorally.
Okay. Any other points outstanding? But it does highlight, this is the point I was making about the transapical, Phil, that in some of these patients where there's so much calcium instead of transcaval, if you've got a really good, it's a mindset. If you've got a really good surgical team and good surgeon who's keen, then you'll get good at it and increase the numbers and then get good results.
Yeah.
So Shaq, I think we've got a couple of more minutes, and rather than delving into the transapical versus other approach for TAVI at the moment, it's probably going to come up in the paravalvular leak session as well. So shall we just broach that topic before we get there, just so that we've dismissed it, because we're talking transapical? Because I think with those, I think because they're smaller sheaths, then there are people just doing percutaneous access and plugging it. And so as a test, when I did the last transapical, I need advice here. I said to the surgeon, you can cut down, but before you close, let me put a plug in and see what it looks like. And so I actually tried a PDA 10mm device in what is obviously a 20 French sheath, which is about 7mm across. And that didn't look too attractive. So next case I do, I'm going to try a 7mm device, because I think it was oversized and stenting. Any thoughts about both the paravalvular leak percutaneous, and also whether we'll ever get to a transapical TAVI percutaneous?
Good question. So who's going to take that one first? John?
Well, I mean,
and then we'll pick on Mark.
I mean, frankly, from the point of view of the operator, I think transapical paravalvular leak is very, very attractive, you know, for some of the mitral valve leaks. It makes our jobs a lot easier, and I think we get a good result. But the problem is that I've found the morbidity actually unacceptable in these patients. I mean, you know, the paravalvular leak group, as you know, Iqbal, are a really, really old and poorly group. And I found that they generally do not tolerate transapical approach very well. And maybe that's our surgeons, maybe that's our setup. We don't do that many paravalvular leaks at all. If you look at the data, big centers are doing sort of 20 a year. So if you're doing 20 a year, of which, you know, 4 or 5 are transapical, it's not really much of a substrate to get good at it. So that would be my take on it, which is why I always approach these by going for a transfemoral route first, and if I fail, then look at transapical. I'll always try the usual percutaneous route. I don't know what you think, Shaq. What do you do?
Well, so we have a low threshold for transapical approach to paravalvular leaks. Not all of them, but if they're posteromedial or medial towards the atrial septum, then we go electively for that. Our surgeons have been very good over the years, and we've not really had issues, either technical or unusual morbidities than normal, really. And it allows us to put, and we put big paravalvular leak devices in with big sheets. And so we've got a better control with surgeons getting the hemostasis at the end as well. Mark? Sorry.
So, does John want to come back?
Yeah, I think it's just, at the end of the day, it's very surgeon dependent, isn't it? And so it's something that we're out of control of. You know, and clearly you've got surgeons that are good at it. And I probably would say that ours haven't cracked it very well.
Yeah, Mark, go on.
Yeah, so there were 2 points really. Firstly, Joe De Giovanni did some percutaneous apical closures, and they didn't all go very well. And so I think the percutaneous approach is a challenging one. Obviously, experimenting is the way to go, and maybe there will be a solution. In terms of the other issue about approaching a mitral paravalvular leak from the apex, is you end up leaving more of the device in the left ventricular side, and I think that's more likely to impinge on a leaflet. So when I do a mitral, I nearly always do it with an agilis through the septum, and by once you've crossed, snaring the wire the other side, you can pretty much get anything across. And then you can pull the device back, so there's as little material as possible on the left ventricular side. And the thing that blocks the mitral leaflet from moving is too much material on the LV side. And that's much harder to judge when you've come from underneath the valve. So I've only ever done one mitral from the apex. I've only ever had to do one mitral from the apex, and actually used it was one of those with multiple small holes, and I used an ABP4, and it'll work fine. But I would much prefer to come from the left, from the venous side through the septum, so that you can really position the device well and minimize the chance of obstructing a leaflet.
So again, we do the opposite for mitrals, especially if they're towards the atrial septum. Pretty much majority of them tend to be transapical. We use the PLD device in the majority of cases. And just taking your point with the PLD device, we leave a bit more of it into the LA and not necessarily yank it all the way into the, so that the waste is in the leak area. And that really sort of gets around having too much device in the left ventricle. Okay, any other points before we wrap up? No, Mark, do you want to summarize, and then we'll move on?
Well, I think that was a really fascinating session. You know, we've all been doing TAVI for a long time, but it's still moving. There are still new things to learn, and I'm very grateful to the speakers for their very elegant discussions of the issues, and to Iqbal for that nice case demonstration. So thank you to all of them. Thank you very much, and thank you to the audience for the questions.
Yeah. All right. Thank you. So let's move on. Inga, we